Hi, everyone. Welcome. It's great to see many of you back for our second week, and welcome to anyone who wasn't able to join us last week and will catch that one in the recording and is joining us for week two. I think we'll give it just a few moments for everybody to join, and then we will go ahead and get started. All right, so let's go ahead and get started. I'm going to switch my internet connection very taking longer than it's supposed to. All right, here we go. So today we are talking about screening. Today's session is going to be, I think, a little bit more focused on the jail context rather than last week, which was a little bit more general. So please do keep, questions coming as they come up. You can feel free to put them in the Q&A as we go, and we can stop and answer them at a point that makes sense, or we'll also have time to answer those questions at the end. So today, like I said, we're talking about screening. Dion Evans from UNC Horizons, as well as me, Andrea Knittel from UNC, will be talking today, and Essence Hairston and Elizabeth Johnson, who were with us last week, will be rejoining us for next week. This is our accreditation statement. We do not have any financial disclosures. There are no financial relationships with ineligible companies. And so those of you who are claiming CME credits or continuing education credits for this session, you can claim 0.5 category 1 credits. And you only need to fill out that evaluation and claim credit at the end of the entire series so that you can claim credit for any sessions that you attended. You do not need to fill out the evaluation for each of the 4 sessions separately. So we are a group of folks working at UNC Horizons as part of our Justice Core Project. As I mentioned, Dion is a nurse at UNC Horizons and one of my personal heroes. I am a general OBGYN at UNC, and I also provide prenatal and gynecology care at NCCIW in the state prison system. Today, we're going to talk about some general guidelines for screening that are applicable to all of the conditions that you might be screening for as folks are coming into your facility. And then we're going to talk a little bit about specifically screening for pregnancy and then screening for risk of withdrawal. And we'll talk about also why we might think about screening as not only assessing for risk, but also assessing for a need for resources and how to get folks to the right places when they do have positive screening results. And then we'll finish it up with how to refer or request technical assistance or training from us, as well as how to send us clients from your facility. So I'm going to hand it off to Dion to go ahead and get started with some general guidance for jail health screening.
I might need to unmute myself. So, a lot of people come in, you got repeat offenders that's going to go ahead and blurt out everything that's going on with them, right? And you got the other people that first time sharing their information, don't know you and kind of hesitant about sharing. One of the things you can let them know is that the information that you're getting for them is for medical, it's for the nurse so she can help take care of them better. And accurate health information is critical for safety. Individuals, again, might be hesitant to share health and substance use information, particularly with custody officers. They feel like, people that has a substance use disorder are judged everywhere they go, from people biased opinions, and we don't want that to happen. Staff who conduct any health or substance use screening should be prepared to explain appropriate confidentiality protections. So, let her know again that this information is for medical, and the more accurate information that medical can get, the better that she can get treatment and the faster she can get treatment. Verbal screening tools rely on self-reporting, collect information that cannot be measured with a urine test, and require trained staff. Like you said, information that cannot be measured with a urine screen. Like when a person comes in and you notice, she can't sit still, she's sniffling, she's doing a lot of, looking at you like she's in another world. That's something that you can look at your eyes and see something is not right with this client. And of course, the urine test screening tools do not rule out dangerous withdrawal, require time and resources. Just when we do them, we usually do the urine drug screening for pregnancy age and the urine pregnancy test. What screening is not: using stereotypes or generalization, asking a person in a public setting whether they are pregnant or use substance, because the jail, there is no privacy when you're doing an intake. You got officers, 3 or 4 officers sitting there, and if they hear something, see the lady 6 months sticking out and hear that she used drugs, everybody's going to stop what they're doing and look up, right? Just because everybody has their own opinion. Relying on judgments about a personal legal problems or charges, and visual assessment only. Just because a person does drugs, that don't make her a drug addict. It can be secondary why she uses drugs. It could be for pain. We don't know. We can't make that assumption right by just looking at her. Screening for pregnancy. Our goal is to identify individuals who require pregnancy-specific care or immediate clinical assessment. That extra mat that we talked about, that double portions that we talked about, making that OB appointment as fast as we can. Additional risk of withdrawing during pregnancy, potential increase in pregnancy complication, risks associated with return to use during pregnancy, and an increased risk of overdose postpartum. We wanted to get this lady treatment as fast as we can. We don't want her, most jails don't like sending people to the ER. And we don't want a pregnancy woman that's not being treated to have early labor. So we do everything we can to keep her having a healthy pregnancy and give her the medicine so when she leaves, that she has a chance.
Awesome. Oh, sorry. Keep going here, Dion. I've got one more.
Okay, deciding on a screening tool. Expert recommendation: every individual of childbearing age should be assessed for pregnancy and offered pregnancy tests at admission. Verbal screening: are you pregnant now, or could you be pregnant? Clinical history interview. Most of them don't know if they're pregnant or not pregnant. Like say, if they are doing drugs, they probably have an irregular period, haven't seen a period, have no idea when their last menstrual period on. So a pregnancy test would be a must. And you can do urine test or blood test. And I think most of them use urine tests.
Absolutely. And so I'm going to just transition now and talk a little bit about screening for risk of withdrawal. Our goal with this screening is really to identify people who need close monitoring for withdrawal symptoms or who need immediate clinical assessment in order to figure out whether or not they need transfer to a higher level of care, either for that monitoring or for assessment. And so some of the big things that we want to think about when we're considering transferring somebody or just making sure that the nurse sees them right away is if they appear unwell or appear intoxicated, if they report or are known, Dion mentioned the frequent flyers that well, folks who have used alcohol or sedatives recently, regularly, and heavily. Those folks are at risk. The alcohol and sedative withdrawals are the withdrawals that can be really life-threatening. And so those are things we want to watch for. And then certainly individuals who report using alcohol or sedatives in the past week and also have had complicated or dangerous withdrawal in the past. And then folks who are known to be pregnant and screen positive for alcohol or opioid use. So either of those withdrawals in pregnancy can be more complicated. And of course, if you've got somebody who is pregnant and has used alcohol or sedatives recently, regularly, and heavily, then you have checked 2 boxes off the list there. And that person definitely is going to need either a higher level of care or immediate assessment within the facility. When we decide on a screening tool, there are a number of different things to think about. One is the time and other resources that you need to implement the screening. There are a couple of terms that we use when we think about which tests to use, and one of them is sensitivity, which is how well the test you use identifies individuals with a substance use disorder. And so when you think about a urine drug screen, it identifies people who have used a substance, but it doesn't tell you whether or not someone has a substance use disorder. And then when we look at specificity, we're really looking at the ability to correctly identify people who do not have a problem with substance use. So we want to make sure that the questions that we're asking allow us to really tell who needs that additional assessment, who needs referral for services, and who does not, sort of irrespective of what their urine drug screen or their charges or their legal issues might be. And so the expert recommendation is that we screen everyone for risk of withdrawal using a brief standardized verbal screening tool. There are a whole bunch of verbal screening tools, and it is certainly beyond the 30 minutes that we have today to go through the details of all of them. There are a couple that are alcohol specific that assess for folks who may have problematic or heavy use of alcohol. There's at least one that really just looks at substances other than alcohol. And then there are a number of different tools that include all of those things. So include alcohol, include other substances. And these various surveys that have been developed that are really both sensitive and specific at identifying folks who have a problem or who are at risk for complicated or dangerous withdrawal. Some of those tools are free. Some of those tools your facility has to subscribe and pay for. They are different. They differ in terms of length, in terms of how much energy it takes to complete them all. And so generally decisions about which tool are going to be used happen either with a combination of the medical and administrative folks in the facility. But it is worth recognizing that whatever your facility's protocol is, that you want to make sure that you're getting a sense of what folks have been using, what route, whether they have been injecting substances or using them in some other way, and whether they've been using with the frequency and the amount that they have been using, so that you get a sense of really what is the risk for this person in terms of their withdrawal. There are also a couple of pregnancy specific tools. Most places other than prenatal clinics don't use them because they're not going to use that pregnancy specific tool when a gentleman comes into the facility and appears altered. You're not going to ask him whether he has used substances in his pregnancy. That is not necessarily a useful thing for the broader population, but useful to know that those tools exist, and that when you take folks to outside appointments, or you have a prenatal provider who is there in the clinic, that they may use screening tools that try to get a sense of what's going on in the pregnancy. And so the 5 Ps that I mentioned there really focuses on whether or not there is substance use in the pregnancy in the past for that client. And then also if her parents, her partner, or her peers or her friends have problems with substance use, because those are all risk factors for having issues with substance use in the pregnancy. And then of course there is also urine drug screening, which I would say that most folks probably use a combination of these verbal screening tools and urine drug screens. And what I would just emphasize is that often, when we do a urine drug screen, those don't assess for alcohol, which is one of the things that can cause the most dangerous withdrawal symptoms. And so it's really critical that we use those brief verbal screening tools so that we can get a sense of what is happening and what someone's risk for withdrawal is, even if that urine drug screen ends up negative, if that person has been drinking heavily or has a history of complicated withdrawal. We want to know that. There is also a whole bunch of terminology, and just like we talked last week about not describing people as addicts, but describing them as people, and really using that person first language, just as none of us would want to be sort of reduced to the kind of the worst decision that we made in our lives or the thing that we struggle with most. I would certainly not want someone to take an inventory of things I didn't do right today and then call me that for the rest of the day or the week. Our clients also, don't need to be reduced to the mental health and substance use challenges that they're dealing with. And so we try to use language that doesn't make people feel bad. And the way I sort of approach it is to think about, if someone described me in this way, would I feel some kind of way about it? Or would I say like, oh, that person is just engaging in a professional fashion with me and describing what is going on? So when we talk about toxicology results, we want to talk about testing negative. We want to talk about drug-free screens rather than clean, because clean implies that it is the opposite of dirty. And our patients who have positive toxicology results are not necessarily dirty, right? That comes with a whole bunch of moral judgment. And so we want to make sure that the way that we're talking about folks is clinically accurate and involves as little stigma as possible. So we can talk about, for those toxicology results or the verbal screening results, testing positive or testing negative. And then when we talk about non-toxicology purposes, again, we talk about folks who are in remission or in recovery. We might talk about folks being abstinent from drugs or not drinking or taking drugs or not currently or actively using drugs. And on the converse, we might talk about someone who is currently, in their active addiction. We might talk about someone who is actively using substances. There is also definitely research that suggests that if we talk about folks in a way that does make them uncomfortable, that they may feel less empowered to make changes in their lives. And so we know that pregnant folks who are using drugs in their pregnancies are often really, really highly motivated to stop and to change their lives, both for themselves and so that they can parent that baby. And we absolutely want to do everything that we can to make sure that we are supporting them in that, even if they have, hit a bit of a bump along the road and have found themselves in your facility. So when we do have a positive screen, there are a couple of things that we can do. Our goal is first to recognize the medical issue that has been identified. So like we talked about last week, we are not identifying moral failings with these screenings. We are identifying a medical problem. And as a result, we want to recommend and refer for appropriate treatment. And so when we have a positive verbal or lab screening for pregnancy, as Dion mentioned, you want to make sure that whatever the pregnancy diet, housing, clothing, et cetera, protocols are in your facility, that those are activated quickly so that folks are getting the care that they need, and that they are referred for either internal or external clinical assessment and prenatal care. And so if that is, that somebody comes to your facility, daily even, or a couple times a week, and sees patients, that if that person is able to provide prenatal care, that this person gets in with them quickly. I have heard from lots of folks, you may be sitting on the phone for a hot minute trying to get somebody an appointment in the community, but those minutes are worth it to get somebody into the care that they need. And when we see somebody who has a positive verbal or lab testing for substance use in pregnancy, we also want to make sure that that clinical assessment happens and that they are connected with treatment for substance use disorder. As I mentioned, most folks who are pregnant and using drugs really don't want to be using drugs during their pregnancy. It is not a volitional decision. It's not a choice in the sense that, you know, you just were walking down the street and thought it would be a good idea to get into this during your pregnancy. And so that clinical assessment related to withdrawal, and we're going to talk about those different kinds of clinical assessments in a little bit next week. And then you want to think about treatment for substance use disorders. So our final session of the month is going to talk about evidence-based treatment. And the first thing that should come to your mind is really medications for opioid use disorder. And so when you've got somebody who is pregnant and is in withdrawal from an opioid, that really the standard of care for that person is going to be getting them connected to either buprenorphine, which is Suboxone, or Subutex, both of which are safe in pregnancy, or with methadone, which is also, you know, the old standby that is absolutely a reasonable option for folks who are pregnant. And so this transitions really nicely to thinking about what we offer and what we do. As the Justice Core group, we provide trainings like the one that you are attending now, focused on evidence-based management of substance use disorders in pregnancy. We also provide technical assistance. And so if you are identifying pregnant people with substance use disorders in your facility, and you're either not sure how to get them connected with medications for opioid use disorder, or you're unsure how to make sure that they make the smoothest transition back into the community as possible, absolutely, please reach out to us. We can help to provide guidance and also make connections between providers of evidence-based substance use disorder treatment, and also to identify alternatives to incarceration. I know we talked about this a little bit last week, but I have yet to meet someone who works in a jail who is excited when someone who is pregnant comes in. Most people are not looking to try and make all those things happen, right? Whether it's the figuring out what the housing situation is going to be, or it's sitting on the phone to get that prenatal care appointment. It would be so much easier if that person could just have their legal issues managed in the community, ideally in a really safe setting, such as a residential treatment program. And so we also offer direct service where we connect pregnant and postpartum people with substance use disorders to residential treatment programs across the state, not just UNC Horizons, although we do have folks who come to us directly from a jail. And we can work with you, with your staff, to identify and really implement those alternatives to incarceration, and hopefully lighten a little bit of the burden in terms of providing all of that care while folks are incarcerated. It is really important that anyone can refer a client to us. And so we'll be sending flyers after this training that have a few more details about who we are and how to reach us. But if you identify somebody who is pregnant or postpartum with a substance use disorder in your facility, please do not hesitate to refer them, ask the nurse to refer them, talk with your supervisor and say, hey, I heard this on this training. I don't know if it's okay for me to make this call. And we can absolutely connect with really anyone at any level of your facility to help make those connections. So I just want to acknowledge our whole team, as well as the funding that we received from the Doris Duke Foundation in order to put on this training. And I've got our email up here for Jamie Jackson, who is our project manager, and then the phone number to request direct service or to refer a client. And then I would love to take questions. And I am seeing, perfect, we've got our first question. Do people stick with the program once they're released from jail? I would say that we have a pretty darn good success rate. Yes. We, over the past couple of years, have worked with, at this point, I think it's more than 150 pregnant and postpartum people who have come from a jail facility or from safekeeping when facilities send folks to the prison for safekeeping, who enter treatment and do really well. And the really beautiful thing about the perinatal treatment programs in our state are that folks can stay with their family. So if they have young children that they were parenting before they were incarcerated, those children can come be with them while they are in treatment. And then certainly their infants once they deliver. Having those babies there is a profound and beautiful addition to a substance use treatment program, and it provides a lot of motivation for folks to stay engaged. Of course, substance use disorder is not something that just goes away. It is a chronic disease like diabetes, like high blood pressure, and like those things. Sadly, there's not a magical medication that we can give someone that just makes everything go away. I will be a millionaire someday if we can figure that out. But
Yeah.
for now, we just our clients do really stay engaged and do really well. Yeah, it's a great question.
And
Other,
the ones
go
I
ahead,
have,
Deanne.
the clients I have spoke to lately that come from prison or jail are thankful for a second chance to be with their kids. So they try really, really hard to make it work for them.
Absolutely. Absolutely. Let's see, other questions in the chat. All right. Let's see, I have a question, Dion, for you while we're waiting for folks to type their questions. Could you just share a little bit about what it looks like right when someone, they leave a jail, maybe somebody from Horizons picks them up? What does it look like right when they get to Horizons?
I do the most of referring. I work at a jail part-time, and I've had 3 or 4 clients that's pregnant in there that I have got connected with Horizons. And you know what amazes me is that is all I do is connect them. In essence, take the ball and roll with it. Essence speaks with the lawyers, Essence speaks with the jail, Essence speaks with all these people to make this thing happen when this girl can get here. By the time I see her, she's at the clinic for her OB appointment. And she's so grateful to get out of that jail, to be there and to have a baby in a hospital. Just normal. I don't get to see that. All of that is in the background, which I think is so amazing. I have text Essence on the weekends and like, hey, this lady is in this jail pregnant. What are they thinking of? And Essence take the ball and roll with it.
Beautiful.
Yeah.
So an unpaid testimonial from Dion about our services.
Yeah.
So you can absolutely call this number and connect folks with us. And Essence, who was on last week and will be back next week, absolutely takes those calls and runs with it. And often it is fast and it is really pretty incredible, I think, how little is required on the part of the person who does the referring. It's truly just that one phone call, and then we are able to take it from there and get folks into the program, work through all of those legal things, and I would say it is rare that we are not able to find a good place that works for somebody when we have been referred a client. So that is fantastic. Well, I will go ahead and wrap it up for today. Thank you all for joining us to talk about screening. Our session next week will be about assessment And that will be some assessment in pregnancy, as well as assessments of withdrawal, as well as figuring out what folks need in terms of resources. So we hope to see you next week. You will get an evaluation link. But as I said, if you're planning to attend either of the next 2 sessions, you can absolutely wait until you've attended the last one before you go ahead and fill out that evaluation. So thank you all very much for joining us. Tell your friends, and absolutely, we will see you next week, same time, same place.
See ya.